Hey, welcome back to the NPTE podcast. This is Will Crane, your host, along with Mark Stevens, and we're here today talking about some case studies. So, Mark, you got a good case study for us.
I do have a good case study for you. So we're going to talk about musculoskeletal today. Musculoskeletal is one of the big sections on the NPTE exam. Is the first section on the list of the breakdown for the content outline. So this is a really, really good place to start. So we're going to do a case study about the shoulder today. So I'm going to go over the cases and going to kind of question Will's clinical brain here. So that's what everyone wants to hear is Will's clinical
That's
brain.
right. I'm going to shoot the brain waves here into the computer monitor, and hopefully they come out on the other side.
All right. So let's read this out here. So this case study, we have a 21-year-old college student, very active in football. That's American football.
American football, okay.
Not British football.
Okay,
so very active in football and cross country. Arrives to therapy with severe left shoulder pain. He denies any traumatic event or previous injury to the shoulder, but does report that any motion involving the shoulder causes pain. It hurts at night, especially when he's laying on his left side. So based on that, what are some of the key things that you're picking up from that, Will, when you've got that case study put in front of you? What are your key words?
All right. So I'm seeing just your average college student, essentially, active college student. They should not be experiencing shoulder pain. I mean, that's just not a normal part of a 21-year-old life. And then the big thing that jumps out to me is that he denies any traumatic event or previous injury. And so on the one hand, I'd say, well, maybe there could be something that in his remote history that he's not mentioning. However, because we don't want to read too much into these questions or these case studies, which is important to do, recognize that, okay, we are denying any significant traumatic event like a foosh injury, a fall on outstretched hand, or any sort of high contact, high velocity injury. So therefore, we have to start asking ourselves, all right, what else could be going on that would not involve some traumatic tear or break? So talking about fracture or rotator cuff tear. So in my mind, we are to kind of start putting those behind us and start looking more at soft tissue injuries, which would be like a tendonitis or a bursitis or a tendonitis or a bursitis.
All right. So you're already differential diagnosing here. So what would your examination pieces are to kind of match that up with where your brain is taking you initially?
All right. So as far as exam goes, with any good exam, you get a detailed history, and we have a semblance of a detailed history. Well, it's not very detailed, but I would ask and probe the patient about when the pain began and what are the aggravating or alleviating factors associated with it. So I would quiz the patient about these things before we began. And obviously, because we're just going to go with that there's no traumatic event, that it has some sort of insidious onset or has been worsening, progressively worsening over time, to the point where now we're starting to get night pain when he is lying on that side. So it's still positional, and that might be something that, at least at first blush, I'd say it's still musculoskeletal type pain because it hurts when he moves it and it hurts when he lays on that side. And so therefore, I'm thinking musculoskeletal type pain, insidious onset. In my mind, I'm automatically starting to go towards a bursitis or an impingement type syndrome. So that would be my history. My visual observation would then go towards asking the patient to move into or towards the painful motions. I would look very closely for the painful arc sign, which, as you recall, the painful arc is where they begin shoulder abduction. It feels not too bad, but then once they hit about 60 degrees, as soon as the scapula kicks in, then they start to experience the subacromial or a reproduction of the pain, especially in the subacromial area. And then once they get above 120 degrees, then the pain seems to dissipate or at least ameliorates to some point. So therefore, I would watch them. I'd have them report on that. I would also after I finished with my observation, I would then do palpation, try to find any areas that are tender to palpation, which would include probing the rotator cuff tendons, the biceps tendon, and the subacromial spaces. So once I did all of that, I would go into strength testing. I would do just basic rotator cuff strength testing. Again, I would not, in this case, I'm not expecting to see anything, but it would be part of my thorough exam, making sure that I have both passive range of motion and active range of motion and strength testing. And then that's when I dive into special tests. And in my mind, once I've gotten to special tests, I've already started my differential diagnosis. Like we're already 95% sure, just trying to put the icing on the cake.
Right. So you've done your examination, you've got your history, you've done all of those things. Your special tests, the whole purpose of your special tests is to confirm you're right. Right?
That's exactly right.
Okay.
So special tests, should we get into the special tests now?
Yeah, let's go for special tests.
All right. Awesome. Thank you. So special tests, we would go into, I think, let's see, should we go into here? Go to the next slide. So anyone who's watching this on YouTube, you'll be able to see all this. Again, big plug for our YouTube channel. Go to YouTube and search for PT Final Exam. You'll find us there. On the special tests list, I would want to make sure to include the near impingement test and the Hawkins-Kennedy test. So if you recall, the near impingement sign is where you raise the arm into full elevation and you're looking for a reproduction of the symptoms. And then the Hawkins-Kennedy test is where you bring the arm into horizontal adduction with some internal rotation, again, looking for a reproduction of the symptoms.
Good. So that's what your special tests, you've done those. So from that examination, this is what we found. So there is no muscle atrophy, redness, or swelling evident, nor was there any indication of asymmetry or ekmosis in the affected area. His neck range of motion was normal. He had a very hard time with any active motion of the shoulder. However, this was because of the pain. You evaluated your scapular motion as well and demonstrated good scapular dyskinesis without winging. Passive motion of the glenohumeral joint was much better than active motion. So passive was better than active. And strength testing was intact but very limited by pain. Shoulder impingement test was positive. Sensation and deep tendon reflexes were also intact. So from that, what is your differential diagnosis?
So highest on the list would be that my working theory is that this is subacromial bursitis or an impingement syndrome with a potential for a rotator cuff tendinopathy or some sort of tendon pathology. And it's definitely possible they could have both, especially where you have the strong and painful description in the strength testing. If you're strong and painful, that typically indicates some sort of tendinitis going on or tendinosis. But as far as differential diagnosis goes, primary diagnosis would likely be subacromial bursitis, followed by rotator cuff pathology or tendinopathy of some kind, followed perhaps by a biceps tendinopathy. And then you get down into the list of, okay, well, what about the labrum? So you're talking labral tears, slap tears, so arthritic type changes, but very highest on the list is the subacromial bursitis.
Okay, well, let's say that it is subacromial bursitis.
Yes.
Well done. Congratulations. We've got it. So subacromial bursitis is kind of what we were going with here. And I really liked the way you broke it down and actually picked out the key words and thought about lots of different things, because that's what our differential diagnosis piece is about, is actually saying, I want to throw out as many things as it possibly could be, and I'm going to narrow it down based on symptoms. So if you've got someone with a subacromial bursitis, what is going to be your intervention? So let's say early intervention, and then a little bit more past that as well, because they are going to differ slightly.
Right. So early intervention would be, because pain is a significant limiting factor in both motion and in sleep, I would want to make sure to include things that had some sort of pain relieving modality. Highest on the list would be ice. To go with that bursitis, I'd try to either do ice massage, do ice, frozen bag of peas, do something to try to reduce the inflammatory response that's occurring in the bursa, especially when you consider that the subacromial bursa has such a little or small space available to it that even if it's just a little inflamed, you'll start to have those symptoms. And so I'd certainly include some sort of icing regimen. As far as joint mobilization techniques, I would try to promote inferior and posterior mobilization of the glenohumeral joint in order to open up that space even more. And so as far as a home exercise program, a Codman pendulum exercise would be good at getting a distraction or long axis distraction. But in treatment, I would focus on especially an inferior glenohumeral stretch or glenohumeral joint mobilization, probably grade 3, grade 4, if possible. If they could tolerate it, maybe only grade 1 or 2 if they couldn't tolerate it very well that first intervention.
Okay. So you're going to be trying to work on some range and trying to get that over, but trying to get the pain and the range aspect in there as well by going for the 3s and 4s.
Right. That's correct. And then the other big part so one of the big main goals in my mind, and I would educate the patient about this, that I would want to make sure that we're getting good inferior mobilization of the glenohumeral joint during shoulder elevation. And that's what the rotator cuff's job. 3 of the 4 rotator cuff tendons, muscles are actually pulling in an inferior, medial and inferior direction. And so therefore, if we can activate the rotator cuff musculature more effectively, especially infraspinatus, teres minor, and subscapularis, if we can get those guys activated, we can get better inferior translation of the humeral head. And so therefore, I would probably start with some sort of isometric moving towards concentric rotator cuff strengthening exercises to try to promote inferior glenohumeral joint mobility.
That's a word.
Yeah, there you go.
All right. So the other thing that I've kind of seen with shoulder issues is posture. Is that right?
Oh yeah, absolutely.
So working on, yes, you're doing the MOBs and you're doing the opening up the joint space, and a good way for a patient to open joint space on their own is to improve their posture.
Right. So scapular retraction exercises, especially the rhomboids, can be especially helpful, especially if they have a forward head, rounded shoulder posture, which like 99% of us do, to bring the shoulders back, have some good scapular retraction, which will improve the mechanics of the glenohumeral joints so that you don't get as much impingement going on in the subacromial space.
Good. So what about as we kind of move through to later in the kind of treatment phase, and as we're starting to progress to getting the patient closer to discharge, what are the kind of things we're going to be going through for carryover, for home exercises, for helping this not happen again?
Right. So maintaining good health of the rotator cuff would be of paramount importance, making sure that we're able to maintain good infraspinatus, subscapularis, and teres minor strength, and not so much. It is certainly strength related, but also the activation of said muscles. And so, what I've seen a lot, and this is how I educate my patients about, is that when their shoulder's hurting, a lot of times when a foot or a leg hurts, we tend to limp, and that's the manifestation of when something is not right. In our shoulders, the limp looks a little different. It's usually a shoulder hike. You get this dyskinesia that was described earlier in the case, where you get upward elevation of the scapula. And I'm trying to do this as I talk, and so those of you who are watching,
it's really good on podcast.
You get to see that. Yeah, really good for podcasting. But so they get the hike, the shoulder hiking, that then turns into bringing their shoulder towards their ear. And they're like, "Look, I can raise my arm," and you're like, "No, that doesn't count." And so the biofeedback of a mirror type biofeedback can be especially useful in retraining the patient, having them watch to keep their shoulder blade and their shoulder depressed while elevating their humerus. So I would definitely educate about that. I would give them home exercises related to the internal and external rotators of the shoulders. So a lot of TheraBand type exercises for internal, external rotation. And then we would practice functional activities. The classic one is to reach overhead with 5 pounds of, imagine you're putting dishes into a cabinet above your shoulder height. So you're trying to lift 5 pounds over your head without having the shoulder hiking or the reproduction of symptoms.
So for this case, this case was how old? 20 something year old?
Yeah, 21-year-old.
21-year-old. So you're telling a 21-year-old football player, I don't want you to do too much. I don't want you to overexert yourself. We're going to work on 5-pound weights. What's the kind of likelihood that you're gonna have to do a do-over with some of these exercises with a young, active, college level athlete?
I guess it depends on how good my education was. I like to point out that the rotator cuff muscles are not the bodybuilder muscles that everyone's trying to get, like their deltoids or their lats or their pecs or whatever. But the vital importance of these small rotator cuff muscles is it's so important that if we don't keep them healthy and strong with these targeted internal external rotation exercises, that they will be overwhelmed by the deltoids doing abduction and forward flexion exercises.
Right.
So education. So they're like, you asked what would the likelihood be that they would not be compliant or that they would not understand. And it would be as likely, the likelihood would depend on my ability to educate the patient on what's actually going on.
I guess I was thinking about myself as a high school athlete or something like that. I was not good. Following, it was like, oh, I feel good today. I feel really good. All right, let's go. Let's do it.
Right, because when you're young, you don't really ever get hurt, right? You're invincible.
Right.
And you can just power through. That's the best part is, you just, what is it? Just grimace and bear it.
That's it.
Or grin and bear it. Whatever you're going to do, just bear it.
And I always say the no pain, no gain does not work with the shoulder.
No, it does not.
Does not work with the shoulder. So if anyone says to you, no pain, no gain, that's not true with the shoulder.
Yeah, not at all.
All right. Well, great, Will. That was a good case study to review. Anything else you want to add?
Just tips for when you're seeing questions like this on the NPTE. So we presented this in case format so we could go through examination, evaluation, differential diagnosis, prognosis, and interventions all together all at once. A test question would test you about one aspect of that. They would perhaps describe the case, a 21-year-old who is experiencing this insidious shoulder pain, what special tests would most likely be indicated. And we went through that reasoning process of, okay, we know there's no trauma, so it's unlikely to be a rotator cuff issue. They have pain when they're putting pressure onto it, so it's high likelihood of being a bursitis or subacromial bursitis. And so therefore we would select the highest value special tests, which we talked about would be like near Hawkins-Kennedy and painful arc, even though painful arc is not necessarily it's a special test and it's also an observation. So it's, which one is it? Is it visual observation and range of motion testing, or is it a special test? We'll leave that for the philosophers to debate. But
right.
Anyway, so we talked about that in light of examination, in light of intervention. Well, I guess before we get to intervention, in light of differential diagnosis, understanding, okay, what could possibly also have symptoms like this. We talked about how a rotator cuff tendinitis could have symptoms that mimic this, especially where it's strong and painful. And it is possible to have both at the same time, the impingement and the rotator cuff tendinitis. And again, when you're seeing that in the question, they would ask you what is most likely to be the case, and they would put things that are likely, like subacromial bursitis or rotator cuff tendinitis, and they'd also put things that are less likely, such as a biceps tendinitis or like an elbow bursitis, an olecranon bursitis, or nursemaid elbow. I don't know why that comes to mind. Nursemaid elbow, or a radial head fracture. And they might put some things that are in the same region, but don't line up to this. Same thing with neck. They may throw in something that, okay, maybe could it be neck related? Possibly, but it's not really stacking up that way.
Right. So that's where your differential diagnosis piece needs to be really, really strong. It's such a huge part of the exam, and it follows through all of the systems. So you could have questions that we need to know, what could it be and what is it? And that's really what they're asking.
Right. And then interventions, like I mentioned in our first episode about don't treat pain unless you see it. And in this case, we we saw that he had significant pain, especially with any motion and especially with side lying. So therefore, one of the key parts of our early intervention would be to reduce the inflammatory response in that subacromial bursa. And so during our early treatment phase, the first 2 weeks, our goal would be to try to reduce symptoms and improve joint mobility. And then longer term rehab would be to improve the strength and function of the rotator cuff musculature and work on functional activities such as raising your arm over your head and avoiding the shoulder hiking that is so common with shoulder injuries.
That's good.
And so they might, it's not likely, but just as far as referral goes, so this is the kind of burning question in the back of my mind with things like this is, okay, have they had any sort of imaging, and what type of impingement are we experiencing? Or do they have a primary impingement, which is related to the bone structure, in which case we can't change that bone structure. We can improve the mechanics as much as possible. Or is it secondary where you have the tendonitis that's just taking up too much space in there? And so with the primary impingement, I would, in the back of my mind, be like, okay, if we're not resolving this within 4 to 6 weeks, we should definitely give them appropriate referral to perhaps get it taken care of, because conservative care is not helpful. And then the other thing that also comes to my mind is the corticosteroid injection that is so beneficial. It's a massive anti-inflammatory bolus of corticosteroids right into the subacromial bursa, which is extremely painful for the patient at the moment because that's where it hurts. But then it brings the inflammation down almost immediately. Well, within a couple of days, I shouldn't say immediately, but it brings it down very quickly and can jumpstart the therapy process, the rehab, in a very dramatic fashion.
Right. And then that's your education piece as well, because some of it, the pain goes away, but they still need to do the therapy. It's like, oh no, I had that and it's good. I'm good now. So just making sure your education piece before they get that kind of steroid injection is all right. This is going to mask a lot of what's going on. But we need to fix the issue. Otherwise you're going to be back again when the steroid injection wears off, doing it again.
Right. So lots of education, lots of coordination with the physician. As far as for referral, it would just be if there was no improvement with conservative care, that's an indication for referral. And honestly, I would, just in a practical sense, I would want to talk with the primary doc, whoever's managing the case, and say, you may consider a steroid injection, which could really jumpstart this whole rehab process if they haven't already had one or considered it. But again, we don't prescribe medicine, so important not to, so my brother's a primary care doc, and it drives him up the wall when he has other non-physician practitioners tell him what medications to prescribe to the patient. He's like, you don't know all the other 55 medications that I'm coordinating with this patient. There's no way I'm throwing them on, fill in the blank other medication. Or maybe it's something, I was juggling 55 others, but this one could help. So a great degree of tact goes with the discussion with the physician. Like, is this something that could be considered? Just at least bring it up so that you don't leave any stone unturned for the patient. You want to be the patient advocate, but you don't want to create, and now we're getting really into the practice, not even philosophical, we're into the practical practice. Can you have practical practice?
Yeah, definitely practical practice.
Not just like mental practice, but this is practical practice of PT, where you have to maintain good relationships with your docs and make sure that the patient is happy, that all the stakeholders are happy. The therapist, the doctor, the patient, the payment provider, everyone happy.
But the patient has to be happiest.
That's right. The patient has to be happiest. Well, yeah. I mean, you got to take care of the practitioner too, because how can the patient be happier if the practitioner can't practice? There you go. Safety first.
We're in a hole now.
Oh dear. Maybe we should come to an end here. Hey, thanks everyone for tuning in to our musculoskeletal case study. We've got lots more to come. We're going to kind of follow the FSBPT's content outline as we go through these case studies, talk about special tests, talk about the examination, evaluation, intervention for these folks. And I appreciate you spending your time with us. Thanks for what you do. And just remember, we've got lots of great resources over at PT Final Exam to help you get through this test.
It was fun to hang out.
Okay, awesome. Until next time, thanks, everybody.
Yep, bye.